It is a pleasure and an honor to participate to this meeting, and despite I've not been able to come in presence physically, I look forward to the time when we can meet again all together. In the present lecture, I will report on available evidence and risk factors for postoperative delirium, and in detail I will report on the clinical relevance, definition, epidemiology, and also on the pre, intra, and postoperative risk stratification. Regarding the clinical relevance, is important to recall that according to Swedish studies, a survey completed by more than 400 colleagues, the neurocognitive preoperative complications, including awareness, agitation, and postoperative delirium, are among the most common complications, but only 11% of the centers do have an available written protocol. The definition of the DSM criteria underline how postoperative delirium is an acute and fluctuating alteration of the mental state that can occur within 72 hours and up to 5 days in the postoperative course, and can be accompanied by perceptual symptoms or cognitive symptoms, and can be characterized by hyperactive and hypoactive or mixed forms. The incidence of delirium vary largely between studies and is reported to occur in 5 to 50% of emergency surgery cases and in 3 to 28% of the elective cases. It is important to underline how the occurrence of postoperative delirium associate with the deterioration in cognition both at short-term and long-term follow-up. In a prospective cohort study in patients undergoing hip fracture surgery, is reported that the occurrence of postoperative delirium complicated 28% of the cases, and in these patients the mortality at 1 year was almost double than in those not presented with postoperative delirium. It's absolutely relevant to note that the implementation of specific strategies dedicated to the prompt diagnosis and dedicated treatment protocols can reduce the incidence of postoperative delirium and improve the clinical outcomes. So we know something, we got to do something. Which are the risk factors for postoperative delirium? Some of those we can detect early from the preoperative phase. Some can complicate the intraoperative course, and some can complicate the postoperative course. Among the preoperative risk factors, it's important to recall that advanced age, the presence of comorbidities, and especially neurological dysfunction, and for this reason the preoperative mini-mental state should be implemented as a systematic element of the pre-anesthesia evaluation, but also the dehydration and malnutrition as chronic pain are preoperative risk factors. For the intraoperative factors, the use of benzodiazepine, especially in elderly patients, extensive blood loss or inadequate volume status, the duration of surgery, the emergency procedure, and depth of anesthesia when too little or too much are predictive factors for an increased risk of postoperative delirium. And in the postoperative phase, the excess of pain and sensory deprivation can contribute to increase the risk for postoperative delirium. Among the precipitating factors that can favor the occurrence of postoperative delirium, there are 5 items that can contribute. And among these certainly the use of midazolam can play a relevant role, and this withdrawal of chronic administration of haloperidol and other psychoactive drugs, but also extensive hypovolemia due to long time of preoperative fasting, but the choice of opioids and the use of alpha-2 agonists can contribute. In detail, the use of ultra-short-acting opioids might associate with an increased risk for postoperative delirium, as well as the use of colloid and especially ESA-starch. So solutions containing starches should be avoided, and for safety reasons, these are now under re-evaluation by the EMA for registration in the European area. As I mentioned above, the use of ultra-short-acting opioid as remifentanil may be contraindicated in patients at high risk for postoperative delirium. Another information of note regarding these patients is that the continuous intravenous anesthesia obtained with total intravenous propofol during the whole phase of surgery associate with an excessive risk on the day 2 and day 3. This preliminary data in a study that we have completed, where anesthesia obtained with propofol or desflurane or sevoflurane, also confirm this evidence. And the total overall incidence of postoperative delirium was 7.4, but in patients treated with propofol, it was more than double than in patients treated with halogenate. Of note, when there is room to use alpha-2 agonist, these might play a protective role in preventing postoperative delirium, and this evidence partially extends to the use of desmedetomidine. The limitation in using desmedetomidine associated with the ultra-short active action of this drug. While the use of ketamine is reported to associate with an increased risk and should be avoided. Monitoring the depth of anesthesia has been reported by some colleagues as associated to a reduction of postoperative delirium, but this evidence has not been firmly confirmed, and there are still conflicting evidence. So both INVOS and BIS-guided anesthesia do not show ultimate evidence for an associated in reduction. The use of the blended use of local anesthesia techniques along with general anesthesia might contribute to prevent postoperative delirium. So which are the tools for diagnosis and which is the timing for treatment of postoperative delirium? It's important, as reported by the guidelines of the European Society of Anesthesiologists, to use routinely in the postoperative period a standardized diagnostic tool as the CAM or the new desk. And this should be administered at least 3 times a day with every nurse shift. This is important. An early diagnostic of symptoms contribute to minimize the complications. So for this reason, the patient's evaluation should become a standard of care. And when the symptoms appear, it's important to establish promptly an adequate therapy that might also include the use of haloperidol. So in conclusion, postoperative delirium should be systematically evaluated for risk factors in the preoperative period and using an established and validated score up to the fifth postoperative day. There are specific risk factors. Some can be detected in the preoperative phase as advanced age, alcohol abuse, pain, malnutrition. Some might complicate the course of surgery as duration of the procedure, benzodiazepine premedication, or the use of alpha agonist. The depth of anesthesia might, when too low or too high, might contribute to increase the risk of postoperative delirium, but it's also important to recall and to implement in the daily practice that a protocol dedicated to prompt diagnosis and effective treatment might decrease the incidence and the associated complications.